Hello, good morning. So, good morning, everyone.
Good morning po.
Okay. So, for today, our second lecture. For today, our second lecture is about disturbances affecting the pumping mechanism of the heart. Our learning objectives is to understand the disorders as to the etiology, pathophysiology, signs and symptoms, and management of patient with infectious inflammatory disorders, congestive heart failure, and pulmonary edema. Okay. So, mute lang po. Corina. Okay, thank you. So, the first, we have in here infectious inflammatory disorders, wherein the suffix for inflammation are that of itis, like pericarditis, myocarditis, endocarditis, pancarditis. Now, anong difference between infectious and inflammatory? So, when we say infectious, the cause of inflammation is the microorganism. Okay. And pagka may infection, may inflammation. Okay? So again, when there is infection, there is always an inflammation. While if there is an inflammation, does not necessarily mean that there is an infection. Okay? Because when there's inflammation, there are several causes like autoimmune, secondary to trauma, but not secondary to microorganisms. Okay, so let's start with the first slide. Okay, so you would see in here, no, if there's inflammation of the outer covering of the heart, no, if there is inflammation of the outer covering of the heart, no, which is the pericardium, then we call that pericarditis. Now, if there's inflammation, if there is inflammation of the inner layer of the heart is the endocardium. So inflammation of the inner layer is endocarditis. And as you all know, the endocardium is continuous with the heart valves. It is continuous with the heart valves. So therefore, if there's inflammation of the endocardium, there will also be inflammation of the heart valves. And that is called valvulitis. Okay? So this is an example, no, of endocarditis. There's inflammation of the inner layer together with inflammation of the heart valves. Again, the term valvulitis. Siyempre, the wound healing will be by development of fibrous tissue formation. And with that, it will affect the valves. There will be inadequate opening of the valves, now which is called valvular stenosis. And the valve can also be regurgitant. It is unable to close adequately, and that is called valvular regurgitation. Okay? When all the layers of the heart are affected or inflamed, then that is called pancarditis. Okay. So, inflammation of the outer covering of the heart is called pericarditis. It could be associated with any of the following. One, it could be secondary to malignant neoplasm or malignant tube growth. And halos wala pa akong nakita na cancer of the heart. But cancer of the lungs is very common. Consider the location of the heart. It is at the mediastinum between the two lungs. So if there's cancer of the lungs, then it can easily go to the adjacent organ, which is the heart, causing irritation, no, to the covering of the heart, causing pericarditis. Idiopathic cause, no? Pag nakita niyo word idiopathic, meaning the exact cause is unknown. Okay? No known cause. Pero nagkaroon ng pericarditis. Third, infective organism, meaning caused by microorganisms, no? Microorganisms. So therefore, pagka-caused by bacteria, viruses, fungus, okay? So ito yung infectious. How does the organism reach the heart? So it could be through the bloodstream, okay? Especially if the patient had an upper respiratory tract infection or probably had a dental procedures, no? And there's introduction of microorganism enrich the heart. Post-MI syndrome. Okay, ibig sabihin, the client had an acute myocardial infarction, that there's necrosis of the heart muscle. Necrosis, there's dead cells. And therefore, it causes irritation and inflammation of the pericardium. Okay? So, ang tawag dyan, Dressler syndrome. Okay. So, another is post-pericardiotomy syndrome. Meaning, the client had undergone a surgical procedure, and then any body tissue will respond to that injury because of surgery with inflammation, pericarditis. Systemic connective tissue disease. Systemic connective tissue disease like rheumatic heart disease. Another, SLE, systemic lupus erythematosus. This is a systemic connective tissue disease wherein abnormal antibodies are circulated in the blood and affect different organs. There's multiple organ involvement with SLE. That it affects the lungs, it affects the GIT, the nervous system, it affects the renal system as well as the heart. Okay? Pagka siya ay connective tissue disease, then that is chronic course. Renal failure. So a patient has chronic renal failure, unable to excrete the metabolites. The metabolites urea, chorea through the urine. And therefore, there's increased level of metabolites in the blood, and then this is being circulated to the different body organs. Again, like the heart, the lungs, the brain, and therefore it causes inflammation. Okay. So pagka chronic renal failure, then pericarditis is also in chronic form. You may add also chest injury. A client had chest injury or chest trauma secondary to gunshot wound, secondary to stabbing, or secondary to vehicular accident. Okay? So, tinamaan ng puso, there'll be inflammation of the heart. Okay? So, tinamaan ng puso, there's injury, to the blood vessels, and bleeding blood accumulate in the potential space in the heart. Okay. Now, according to course, it can be acute or chronic. Acute is short course, usually less than 6 months. And if it extends more than 6 months, then it is called chronic pericarditis. Like malignant neoplasm, o meron pala siyang cancer of the lungs, kung ilang taon na niyang dinadala yung cancer of the lungs. So therefore, there'll be chronic pericarditis. Okay? Idiopathic, dahil hindi alam ang cause, so it can be acute or chronic. Infective organism is acute. Dapat ma-address na agad, ma-control na agad yung infection para hindi naman siya maging chronic. Post-MI syndrome, after MI, so therefore acute course, acute pericarditis. Post-pericardiotomy, acute also. Systemic connective tissue disease, chronic. That's chronic pericarditis and renal failure, chronic. But secondary to trauma, then that is acute pericarditis. Okay. As long as there is inflammation, okay, there'll be signs and symptoms of that redness, there'll be chest pain, so there will be limited function, okay, or lack of function, and the wound healing will be by development of fibrous tissue formation. Kaya with chronic pericardial inflammation, with chronic pericarditis, there is fibrous thickening of the pericardium. So ibig sabihin, no, so the pericardium is hard. It is rigid. Ayun, rigid pericardium. And therefore, there is increased pressure in the pericardial cavity, and it affects venous return. It affects the amount of unoxygenated blood entering the right side of the heart. So there's inadequate ventricular filling, okay, leading to heart failure. There's inadequate ventricular filling. No? There'll be less blood would flow into the ventricle. There'll be less preload, okay? Because there is rigid pericardium. Okay. So the signs and symptoms, just like any other organ, no, na namamaga, then there will be pain. So there will be pain. Initially, there will be swelling. Okay. There will be a loss of function. Okay. Surgery. Tumatawag na naman si Ma'am Rosel. Okay. So there'll be chest pain, radiating to the neck, shoulder, and back. Okay, so the pain in here is secondary to inflammation. Okay, not yet the pain secondary to imbalance between oxygen supply and oxygen demand. And therefore, physically, no, namamaga ang puso, and the pain is aggravated by physical movement, like when the client do inhalation or inspiration, when the client had coughing and swallowing. Okay, so actual physical movement, no, can aggravate the chest pain. It is worse in supine position and relieved by sitting up and leaning forward. Okay, because if there's inflammation of the parietal and visceral pericardium, there'll be fluid exudation in the potential space. It will lead to accumulation of abnormal volume of fluid in the pericardial cavity, and that is called pericardial effusion. Pagka siya ay nakakaiga, lying supine, and then practically the heart is surrounded by the fluid. Kaya nagiginhawahan siya if the patient is seated or leaning forward. Okay. And then, there'll be pericardial friction rub, yung rubbing of the parietal and visceral pericardium, producing sound like that of a leather shoes, no, being rubbing against each other. The scratchy, high-pitched sound. And if with chronic constrictive pericarditis, there'll be signs and symptoms of right-sided heart failure. Paano diagnosis? To the echocardiogram, CT scan, it will reveal thickening of the pericardium because there's inflammation or infection kung microorganism, then there'll be increase in WBC count. There'll be leukocytosis because it will simulate the cellular response, no, to do phagocytosis. And atrial fibrillation is also common. So mahihirapan si atria, no, to pump blood, no, going to the ventricles. Okay. Paano nga yung complication? The complication is accumulation of abnormal volume of fluid na normally, gano'n nga lang ba ang volume natin? Di ba, it's about 15 to 20 ml. Now, pagka may pericarditis, pericardial effusion, the fluid can be 50, 100, 200, 300. Worst scenario, can be 500, can be 1 liter, 1,000. Okay? Kaya sinabi, potential space. Kaya kung siya ay 1,000, naku, it is really constricting to the heart. Nahihirapang mag-pump ang puso. Okay? So therefore, what are the interventions? So the interventions are NSAIDs. Kailangan natin dito non-steroidal anti-inflammatory drugs. No? What are example? What are example of these drugs? No? Example of that of naproxen or naproxen, Indoseed. Okay, apply pharma ha. Okay, Lucy, Jane, pakimute please. Ano pa? Indomethacin, aspirin, okay, NSAID, because this will inhibit the release of prostaglandin, which is which cause the pain. Unlike chest pain of angina pectoris, ayon ay secondary to imbalance between oxygen supply and oxygen demand. Kaya ang gamot nila ay vasodilator. Ito, there's chronic physical and inflammation, no, of the heart. Kaya kailangan natin NSAIDs. By the way, ang NSAIDs are gastric irritants. It causes GI upset. So therefore, NSAID should be given before meal or after meal. Please answer. Kailan bibigay ang NSAID? Before meal or after meal?
After meal.
Okay, no, full stomach should be given after meal. AC or PC? After meal. AC or PC?
AC.
Okay, PC, post sebum. Thank you. Okay. If the cause is autoimmune reaction, like yung ating mga SLE, okay, edi bibigyan natin ng corticosteroids. Okay, corticosteroids na like a prednisone if the cause is autoimmune, like SLE. Antibiotics. Sino bibigyan natin ng antibiotics? If the cause is microorganisms. So it could be antibacterial, antiviral, antifungal. Okay? So by the way, patient had pulmonary infection caused by tubercle bacilli, may TB of the lungs. No? So patient can have the spread of infection also in the heart. So therefore, antibiotic na bibigay natin doon sa pasyente na yon is anti-TB regimen. Okay? Now, whatever is the cause, okay, and whether inflammatory or infectious, the complication is pericardial effusion, which inhibit the entrance of blood into the heart chambers. So therefore, we have to remove the fluid. And mechanical removal of the fluid is called pericardial drainage. It can be done by the use of syringe and needle, pericardiocentesis, or by the insertion of a tubo. So that is pericardiostomy. Okay? Kung minimal lang yung volume, tubo na ilagay. Okay? To decrease the pressure inside the pericardial cavity. Then, if the cause is cancer, malignancy, then syempre mamanage siya ng radiotherapy. Okay? Radiotherapy kung sa cancer of the lungs, chest, no, radiotherapy or chemotherapy. Okay, so sino magre-radio? Chemotherapy, no? Magre-radio and chemo kung ang cause ay cancer. Okay, like, no, so we had a patient, no, na taga dito sa Bulacan. Okay, about 60-year-old din, no, nung ma-admit siya, had the chest pain. At sinugod agad, no? Kasi ang cardiologist niya ay connected din dito sa USC and therefore was brought by ambulance, no, to USC Hospital. We removed from Malolos, no, by ambulance, no, to USC. Okay pa, nakayanan niya yon. And then to the echocardiogram was done and the fluid was about 1 liter. Could you imagine nga? 1 liter, 1 liter na Coke pala ay kasya sa puso. Okay? Since marami yung fluid, so the surgeon opted to remove the fluid by tube, by pericardiostomy. Kasi kung ang gagamitin lang niya ay syringe and needle, ay medyo matatagalan yun, nakakapagod yun. Okay? And the fluid which was removed was sent to the laboratory for gram staining, for culture and sensitivity, okay? Para malaman din, no? Culture and sensitivity para malaman kung ano bang mikrobyo, no? Mag-grow doon. And also, the fluid is sent to the laboratory for histopathologic studies. And do you know the findings? Do you know the result? The fluid is positive for cancer cells, which can only be seen in the lungs. Kung ganun, siya pala ay may cancer of the lungs. So hindi alam, no, na may cancer pala siya. And the cells, no, the cancer cells reach the heart, causing irritation to the heart. Kaya nagkaroon siya ng pericarditis. Pero hindi na nabigla ang lahat because his father died several years ago because of cancer of the lungs. Okay? So, ang management niya, hindi lang pericardial drainage, kundi pagka medyo lumakas na siya, she will be submitted for radiotherapy or chemotherapy or combination of both. Then, if the cause is renal failure, that is called uremic pericarditis, edi ang option is hemodialysis. Okay. Si nephrologist, in doctor niya para sa kidney, nephrologist, no, will just increase, no, the session of dialysis. Kung si patient ay twice a week ang dialysis, since ang fluid pala ay nagpunta to the third space, no, to the pericardium, okay? Nagkaroon ng fluid in the third space, no, because of pericarditis. Then, ang kanyang suggestion, mag-dialysis 3 or 4 times a week. Siyempre, since si patient ay may cardiac problem, nagcho-chest pain, magkokonsulta yan talaga sa cardiologist. Pero para kay cardio naman ay magsasuggest siya ng mechanical removal of the fluid wherein the patient will undergo pericardiocentesis. Okay? So si uremic patient, no, ay joint management ito ni cardio at saka ni nephrologist. Okay? And let the patient assume that the position of comfort. Ano nga yung position of comfort? Sitting position, no? Leaning forward. Okay. And if there's chronic constrictive pericarditis, then patient is or advised to undergo pericardiectomy para mabawasan yung pressure inside the heart, para madali makapasok yung unoxygenated blood. Okay? And monitor for complications that of pericardial effusion. So ito nga yung volume 50 and above. Okay? So kaya maka-accommodate, no? Kasya 500, 1 liter. Okay? Parang ang hirap noon, no? Na imagine mo ito yung puso mo. Ayan ang puso, tapos nababalot siya ng fluid. So there's fluid build up, no, within the pericardial sac. Okay, so therefore, it affects the pumping ability of the heart. It affects the amount of blood na papasok dito sa right side. So kung less ang blood na papasok sa right side, ano naman ang ipapump ni left side? So less blood in the right side, di ba? Di, kung gaano ang pumasok, yun lang din ang mai-out ni left ventricle. So therefore, there'll be low cardiac output. Okay. So, all right. So monitor for complications that of pericardial effusion, which could progress to cardiac tamponade. Okay. So actually, pagka, some books will say pagka 100, 200 and more, tawag na nun, cardiac tamponade. Okay. So anong effect? We have triads, no? So we have Beck's triad na tinatawag, given by Dr. Claude Beck. Okay? we have the Beck's triads. No? May three major manifestations. One, at mo yung pathophysiology. Diba? There's fluid buildup dito. So therefore, mahirap pumasok yung unoxygenated blood na tinrace natin kahapon. And therefore, there will be neck vein distension. So one manifestation is jugular distension, or you can call this neck vein distension. At anong ebidensya? Mataas ang CVP. There's increase in central venous pressure. Okay. Ano pa? Okay, so there's decreased unoxygenated blood, there's decreased ventricular filling, kaya less din ang ating cardiac output. Okay. So, ano ebidensya? Less cardiac output. There's cardiogenic shock. There is cardiogenic shock. Kaya ang arterial BP is very low. There's hypotension. There's hypotension. Plus, hypotension there is a still exaggerated fall in blood pressure during inspiration. It is about more than 10 mm mercury. So, ibig sabihin, bagsak na yung blood pressure natin, hypotension, palpatory, no? Tapos, no, the patient, pag nag-inhale, babagsak pa ng 10 mm mercury or more. Okay? At anong ebidensya? Bagsak pa ang blood pressure. Nawala ng pulse. Disappearance of pulse. So, this is pulsus paradoxus. Okay? So, the second triad is hypotension with pulsus paradoxus. Okay, there's low cardiac output. So there is shock. What type of shock? Cardiogenic shock. Okay, cardiogenic shock. There's circulatory failure. There's hypotension. There's altered tissue perfusion, secondary to inability of the heart to pump. And there is muffled heart sounds. Heart sounds, diba? We have the S1 and S2. S1 is heard secondary to closure of atrioventricular valves, while the S2 is heard secondary to closure of semilunar valves. So there's faint or distant heart sounds. Halos hindi mo marinig yung heart sound. Of course, there's circulatory collapse. Again, what are the Beck's triads? One, there is jugular distension or neck vein distension. Ebidensya, high CVP. Pangalawa, there's hypotension with pulsus paradoxus. Okay? Na mababa nga yung blood pressure. Tapos when the patient inhale, there is further drop in blood pressure, more than 10 mm mercury, as evidenced by disappearance of pulse. So ang pangalawa, hypotension with pulsus paradoxus. Pangatlo, there's distant or muffled heart sounds. Okay, triads. Ngayon, anong effect ng decreased cardiac output? Because of decreased amount of blood pumped by the heart, there'll be decreased oxygen, which will be delivered to all the body cells, especially the brain. So, anong effect on the brain? So, the patient initially has disorientation, confusion, restlessness, until stuporous and comatose. Okay? So, because of altered cerebral perfusion. All right? On the respiratory system, so there will be tachypnea. Okay? Mahirapan siyang huminga. There's rapid breathing. Palpate the skin. There's cold, clammy skin. There's increase in perspiration. Okay. Then, punta tayo sa kidney. Anong effect on the kidney? On the kidney, there'll be altered renal perfusion. At anong ebidensya? Low urine output. So, my dear students, pag ang pasyente had oliguria or anuria, low urine output, expect kasama nun ay mataas ang metabolites, mataas ang BUN creatinine level. Okay? So mataas ang ating BUN and creatinine level. At kung oliguria, hindi mailalabas yung electrolyte, potassium. Ayan, sama-sama yan ha. Pagka there's decreased urine output, expect no, mataas ang BUN creatinine level, may hyperkalemia. Patient can have the renal shutdown. Okay? Secondary to circulatory collapse, secondary to altered tissue perfusion. Okay? The triads, ito yon. Jugular distension, hypotension with pulsus paradoxus and distant or muffled heart sounds. And the emergency care, emergency intervention, okay, is removal of the fluid, mechanical removal of the fluid, and that is called pericardiocentesis. Pericardiocentesis. Okay? So, when we say pericardiocentesis, ano lang ginamit ni doktor? Ang ginamit niya dito ay syringe and needle. Okay? So, subxiphoid approach, no, syringe and needle, tusok, kagaya ng posisyon, parang fluid, iba bababa. So bababa ang fluid by gravity. So in here, anong nakita niyo ang nakuha ni Dr.? Blood. So therefore, this is hemopericardium. Hemopericardium. So blood, secondary to chest trauma. Okay? So one cause is chest trauma. So the fluid, okay, is the syringe, no, is connected to a drainage bag. Kung wala man drainage bag, edi manually it will be placed in a drainage bottle. Okay? So this is life-saving measure. So what are our nursing responsibilities if your patient is for pericardiocentesis? Of course, we have to obtain consent, no? And explanation of the procedure, kung ano yung gagawin, is primarily the responsibility of the doctor. It is done under strict aseptic technique with local anesthesia. Local anesthesia. So nurse, no, we have to do skin test to xylocaine. Prepare the equipments needed. Na kailangan natin ng pericardiocentesis set, kailangan mo din ng equipments for skin prep, no? Equipments for skin prep, like you have the pica forceps, you have the cotton balls with betadine, so the gauze, the plaster, the bandage scissor, si doktor ay naka-gloves, kaya you have to prepare the sterile gloves, no? The gown. Ngayon, panahon ng pandemic, no? Kaya naka PPE si doktor, okay? So naka face mask rin siya, okay? But before the pandemic, no, just the sterile gloves ay okay na, okay? Pero ngayon, kung panahon ng pandemic, no, sa kailangan ng magsusot siya ng PPE. Si patient, no, will be given the oxygen therapy and meron siyang pulse ox para ma-measure ang O2 saturation during the procedure. Okay? And better, connected siya sa cardiac monitor para nakikita, na-evaluate ang cardiac activity during the procedure. Okay? So, ayan, no? Andito yung ating the sterile field. So the doctor will remove as much fluid as he can. The doctor will remove as much fluid as he can. So hanggang saan ang maaalis niya. Pag nakatanggal siya ng fluid sa pericardial cavity, mababawasan ang pressure inside. Anong effect? E di makakapasok na ang venous return. Makakapasok na yung dugo natin sa coming from superior and inferior vena cava to the right atrium, to the right ventricle, and so forth. Kaya gaganda na yung cardiac output, gaganda na yung blood pressure, gaganda na yung tissue perfusion. Kaya this is a life-saving measure. Okay? Ito kasi yung pinakamadali. Pero since this is blood, patient probably is a victim of chest trauma. So when the vital signs are already stable, then patient can already be brought to OR for an operation. Probably repair of lacerations, no, kung ano man ang nangyari, no, so because of the chest trauma. Pero kung siya ay secondary to medical condition lang, like uremic pericarditis, no? Or secondary to SLE, no need for surgery. Ang management lang doon ay drug therapy. At saka yung uremic pericarditis, isasabayan nga natin ng hemodialysis. Okay? So, ang operahan lang yung victim of chest trauma. Alright? So, remove as much fluid as he can in order the unoxygenated blood to enter the heart at mag-improve yung ating cardiac output, tataas na yung ating blood pressure. Okay? So that's it, no? Pericardiocentesis, a life-saving measure. Pero kung maraming fluid, tubo, di ba? Kung maraming fluid, 1 liter, tubo. Ang tawag, pericardiostomy, tubo. And that tubo is connected to a bag to continuously drain the fluid. So yung pasyente nga na kwento ko from Malolos papunta sa UST, initial drain, 1 liter. Then, hourly, the nurse has to drain the fluid. Could you imagine? Hourly drainage, 60 to 70 ml. 60 to 70. Ibig sabihin, there's continuous production of pericardial fluid. Okay? So the fact that the patient has pericardiostomy, so the client is on bed rest, no? So mahirapan din siya na out of bed, no? Mahirapan mag-out of bed, kaya remain on bed, no? On complete bed rest. Pero we have to provide or ask the patient to do range of motion exercises. Gising naman talaga yung pasyente, no? Kaya lang, because the client remains on bed, there's decreased mobility, there's circulatory stasis. Ibig sabihin, mabagal ang circulation, blood circulation, and the client is at risk to develop thrombus formation, deep vein thrombosis. You know, the patient spent several days in the ICU, tapos so medyo stabilized na talaga siya, then nasa ordinary room na siya doon sa hospital sa UST. No? So nadalaw namin siya. Okay. Now, ang ganda-ganda na ng pakiramdam niya. Until noong ika-10th day, complained of leg pain. There's leg edema. Na-confirm na meron siyang deep vein thrombosis. Meron siyang deep vein thrombosis. And, alam mo po, anong susunod na araw, 11th day, madaling araw, complained of severe DOP and severe chest pain. The patient died. Anong kinamatay niya? Hindi dahil sa cardiac tamponade, kundi dahil sa pulmonary embolism. Okay? So, ibig sabihin, yung deep vein thrombosis, thrombus na bakbak, and it goes to the circulation and causing massive pulmonary embolism. Okay? Kaya, moral lesson, don't be complacent. If your patient is comatose, paralyzed, no, na nandito lang sa bed, tahimik, we have to provide some form of mobility, like range of motion exercises, no? Tapos, no, yung kung gising naman ito tulad ng pasyente, can have the active exercises. Pero si patient talaga, ang trabaho niya po ay may kantin sila, kusinera. So therefore, the nature of the work, no, madalas siyang nakatayo at meron siyang leg varicosities. Meron siyang leg varicosities, no? And ito yung predisposing factor niya para magkaroon ng deep vein thrombosis. Okay? Pero sabi nga namin, ang tibay, no, na nakayanan niya yung 1 liter na fluid na yun, no, papunta sa USC from Malolos, no, tapos ang kinamatay niya, hindi cardiac tamponade, no, kung hindi pulmonary embolism. Naalala niyo yung aking hemodynamic monitoring kahapon, ano yung pwedeng bumara doon sa pulmonary artery branch, di ba, when the balloon is inflated. Pero this time, with this client, yung thrombus, no, naging embolus, thromboembolism at bumara sa pulmonary artery, just the same. No? So there'll be pulmonary infarction and dead space. Kaya nagkagulatan ang pamilya kasi alam na nakaka-recover na siya. Inihahandaan na ang kanyang treatment para sa chemotherapy or combined with radiotherapy. Okay? So, moving on. Myocarditis. Myocarditis is inflammation of the myocardium, the one responsible for contraction. Again, take a look at the causes. Halos pareho lang yan. Infectious, virus, bacteria, fungus, no? Pwede rin chronic alcohol and cocaine abuse. Or secondary to radiation therapy. Ano naman yung radiation therapy? Ito, sino ba yung nagre-radiation therapy? Then may cancer. Radiation therapy of the chest. So probably, ang pasyente may cancer of the lungs. O kaya cancer of the breast. Kaya na nagre-radiation therapy, nadadamage din ang puso. Autoimmune disorders. Anong autoimmune disorders na to? Yung SLE, systemic lupus erythematosus. So kaya rheumatic heart disease. Idagdag pa natin. Bulimic patients. No? Taking Ipecac syrup to facilitate purging. And therefore, this cause myocardial damage. Bulimia. Okay, so this is an abnormal behavior, okay, a psychiatric disorder, wherein the client, no, it has excessive eating, kain ng kain, bulimia, kain ng kain, pero takot naman siyang tumaba. Kaya, do something, no, para mag-vomit siya. Either by the use of Ipecac syrup o kaya ay dukutin niya, no, ang kanyang lalamunan para siya ay mag-vomit at para hindi siya tumaba. Siyempre, yung ating gastric, no, nagsuka. So siyempre, the gastric secretions are really highly acidic and this can cause damage to the heart. Okay? And the last cause din ay idiopathic, no, for unknown cause. All right? But usually, myocarditis is viral cause. Now, dahil syempre namaga ang puso. There's myocarditis, namaga. Kaya magkakaroon tayo ng chest pain. There'll be fatigue, abnormal function. Ibig sabihin, there's decreased myocardial contraction, decrease in cardiac output. At alam nyo na, pagka decrease in cardiac output, there'll be altered tissue perfusion. Okay? Altered tissue perfusion, magdi-DOB yan, no? There's activity intolerance, there's tachycardia, there could be dysrhythmias, okay? So there will also decrease renal perfusion, and therefore, there'll be decreased urine output. Ayun. So, because of decreased function, myocardial contraction, magkakaroon tayo ng decreased cardiac output, altered tissue perfusion, impaired blood circulation, and this is another cause of congestive heart failure. And because of ischemia, there's tachycardia, there is dysrhythmias. Okay, and the complication, the chronic complication of myocarditis is cardiomyopathy. Ano yung cardiomyopathy? So this is abnormal dilation of the heart, abnormal enlargement of the heart. Okay? Kasi di ba si myocardium mismo ang namamaga, kaya ang compensation niya is there is dilation. Dilation is stretching of the heart muscle. Because if you will recall, the more stretched the heart muscles are, there'll be more ventricular filling. Ibig sabihin, maraming dugo ang papasok sa ventricle, and therefore it will be able to create a greater contraction. So that is Frank-Starling law. The more stretched the heart muscles are, there'll be more ventricular filling. It will be able to create a greater contraction. While another is, there's be increase in size and diameter of the myocardial cells. So that is called ventricular hypertrophy. Pero mga ito ay effective only up to certain point, after which no, there will already be a decompensation. Kaya it remains no, enlarged and dilated. Yun ang cardiomyopathy. So it affects ventricular filling, and there is also decreased cardiac output. Okay? So kung kanina pericarditis, ang complications, pericardial effusion, cardiac tamponade. Pag myocarditis, ang complication is cardiomyopathy. Okay? So abnormally enlarged ang puso. All right. Kaya ito yung common signs and symptoms. There's pain, fever, there's tachycardia, dysrhythmias, DOB, malay, no? Fatigue, there's anorexia, there's pale or cyanotic skin, there's signs of right-sided heart failure because of inflammation. Siyempre, mataas ang WBC, there's leukocytosis, there's elevated CRP or C-reactive protein, and there's damage, myocardial damage. No? So there'll be elevated cardiac isoenzymes and abnormal ECG. Okay, chest X-ray reveal also abnormal findings. There's cardiomegaly, malaki ang puso, as well as 2D echocardiogram. But the most definite test is endomyocardial biopsy. A sample tissue will be taken to the myocardium by the use of a syringe and needle, and then it will be examined for histopathologic studies or dili kaya for gram staining, culture, and sensitivity test. So yun yung most definite test. Okay? Intervention. Just like kanina, pericarditis, so the management will depend upon the cause. And kung infective, edi kailangan natin na antibacterial, antiviral, antifungal, depending upon what organism. Okay? So we have to promote bed rest. No? Kasi syempre there's activity intolerance because of altered or decreased cardiac output. Kaya we have to place on bed rest. Diet, no? Because there could be a fluid retention, a low sodium diet. And a drug to improve the pumping performance of the heart, to improve the contraction, no? To strengthen the force of cardiac contraction. So we have here the digitalis. So we can call this digitalis also as cardiotonic, inotropic, no? So it will increase the force of cardiac contraction. So digitalis is given. And of course, monitor cardiopulmonary status and complications. Ano nga yung complications? CHF, dysrhythmias. Okay. So, ano yung mga i-monitor natin? Monitor the vital signs as well as the level of consciousness. Monitor the weight. Okay. With regards to the weight, the best time to get the weight is in the morning using doing it same time, same weighing scale, same clothing. Okay. Monitor intake and output. No? Ano pa yung monitor? Heart sounds, lung sounds, no? Pulse ox, measurement. Okay? Patient can have the ABG, pero hindi naman natin pwedeng gawin yun every now and then. At least we monitor the O2 saturation, no? Using pulse oximetry, 95 to 100%, no? O2 saturation. And cardiac monitoring. So the patient is connected to a cardiac monitor. Okay? Kung hindi man siya nasa ICU, siya ay nasa regular ward, pero magre-rent tayo ng cardiac monitor. Kung siya ay nasa regular ward, ang rule, we have to pay the cardiac monitor daily. Okay? And monitor for dependent edema, leg edema. Okay? Myocarditis. Now, moving on. Rheumatic fever. Okay? Halos review na lang sa inyo to, no? Kasi meron kayong discussion ito in your pedia. Okay? Ano yung rheumatic fever? This is a systemic inflammatory disease that develops after an upper respiratory tract infection. Ano yung upper respiratory tract infection? So these are tonsillitis, pharyngitis, laryngitis, okay, ATP, acute tonsilopharyngitis. Okay, and this is caused by GAB. Sino si GAB? Si GAB is group A, beta hemolytic streptococcus. Okay, so the client has or had manifestations of an upper respiratory tract infection caused by GAB, group A, beta hemolytic streptococcus. Okay, and pagka ang puso ay affected na, so we call the condition rheumatic carditis or rheumatic endocarditis. So anong pathophysiology? Because of exposure to GAB, group A beta hemolytic streptococcus, antibodies are formed to destroy GAB. Okay? Antibodies are formed to destroy GAB. And a blood test which will reveal exposure of the client kay GAB is an increase in ASO titer, anti-streptolysin O titer. Ayan. So upon exposure kay GAB, antibodies are formed. And then, these antibodies mistakenly cross-react against the proteins in the connective tissues of the heart, the joints, the skin, and nervous system. If all the layers of the heart are affected, pancarditis. Kaya with rheumatic heart disease, patient can have the pericarditis, can have myocarditis, can have endocarditis. Okay? So bakit sinabing autoimmune reaction? Kasi antibodies, no, destroy the body's own cell, particularly the heart, joint, skin, and nervous system. Now, because of inflammation, diba, namamaga ang ating mga connective tissues, then there'll be the cellular response. Okay? So the WBC in particular will go to the site of inflammation para magkakaroon ng phagocytosis. And the result of that phagocytosis is development of inflammatory debris or what we call vegetations around the valve leaflets. Kasi sabi natin, di ba, pagka may endocarditis, there will be valvulitis. And mamamagay mga valves, at saka end product ng giyera, okay, the end product of phagocytosis, no, because of that cellular response is formation of inflammatory debris or tinatawag nating vegetations. Kaya in the future, pag nakita yung word vegetation, ibig sabihin the client has endocarditis. Okay? Ano yung mga vegetations na yan? Okay? So, vegetations, ito yung ating mga normal valves, okay? Ito yung healthy valve. So the healthy valve is able to open completely and close adequately. Okay? So an infection of the innermost layer of the heart, no, that is endocarditis. It may occur in people with congenital and valvular diseases or those who had rheumatic fever. So those who had exposure to GAB, nagkaroon ng valvulitis and valvular defects. So therefore, that is acquired. Diba? Nagkaroon ng upper respiratory tract infection, nagkaroon ng RHD, nagkaroon ng valvulitis. In some individuals, no, bata, it is congenital. Pero this time, nirelate natin na ang pasyente nagkaroon ng upper respiratory tract infection at nagkaroon ng RHD, nagkaroon ng endocarditis and valvular defect, that is acquired valvular defect. So again, this is the healthy valve. It is able to open completely and close adequately. And ito yung mga vegetations na pinag-uusapan natin, either sa labas or sa loob, ang mga vegetations na yan. Ano nga yung vegetations? These are dead cells, dead organism, the result of phagocytosis. Vegetations in here. Okay? So there are vegetations, no, in the mitral valve. There are vegetations in the mitral valve. There are also vegetations in aortic valve. Anong effect ng vegetations na yan? It can cause obstruction with the flow of blood. It can cause obstruction with the flow of blood from atria, left atrium, to the ventricle. Kung aortic, no, valve ang affected, it can cause obstruction with the flow of blood from the left ventricle going to aorta. It can cause obstruction. Ano pa? Diba? The fact that the patient has endocarditis, no, can be acute or chronic, namamaga yung ating valves, and wound healing will be by fibrous tissue formation. Kaya magkakaroon ng valvular stenosis. So makipot na nga yung valve, mayroon pang vegetations. So yun ang mga bumabara. So as blood from the left atrium pass through, these vegetations could embolize. The vegetations could embolize. Ibig sabihin, natanggal. And it goes with the circulation. It goes to the aorta, ascending aorta to the brain. Madalas napupuntahan si brain. So therefore, patient will have a stroke, cerebrovascular accident, embolism type. Or this can embolize in any part of the body. Pero ang danger ay sa brain. Cerebral embolism. Okay. So ano pa? Habang as the blood pass through the atria to the ventricle, di ba may bara, may obstruction, makipot ang daan, may vegetation, the blood cells are trapped. Nasasabit ang blood cells na dumadaan dyan. Particularly the platelets. Therefore, patient is at risk to develop thrombus. Di patong-patong na sila dito. Okay, meron na nga tayong vegetation. May thrombus pa dito sa ating valves. Naku po. Kasi may bara makipot. There's valvular stenosis. Tapos ang daming nakaharang dyan na vegetations. Kaya pag ang dugo ay dumaan dyan, masasabit ang ating platelets at magkakaroon ng thrombus. Nasaan ang thrombus? Ang thrombus ay nandini, no, sa ating mga valves. Okay. Adi lalong maraming bara, maraming obstruction. And mahihirapan si left atrium to pump blood, no? Kasi maraming bara dyan. Kaya there's retention of blood in the left atrium. There's stasis of blood in the left atrium. Kaya pwede rin magkaroon ng thrombus dito sa left atrium. Mahirapang mag-pump siya, kaya magkaroon siya ng atrial fibrillation as a complication. Kung ganon, ano po ang types of emboli ng pasyente na may endocarditis? One, it could be vegetation. Pangalawa, it could be a dislodged blood clot. Okay? Na delikado nga, pag ang pasyente nagkaroon ng altered level of consciousness, nagkaroon ng paralysis sa one side of the body, alam mo na yon. So the patient had a stroke. Okay? Cerebrovascular accident, thromboembolism type. Embolism type. Okay? So yun ang kinakatakutan natin, no? Pag endocarditis. If considering pericarditis, myocarditis, endocarditis, alin nga yung more common? Alin ba ang more common? more common ang endocarditis because the endocardium has direct contact with the patient's blood. Okay? Na ang pasyente nga lang no, magkaroon ng dental infection, bulok ng ngipin, or had that dental operation. Okay. Kaya yung mga IV drug users na nanghihiram ng syringe, okay, they are traced for endocarditis. Yun naman, pagka hindi siya autoimmune but caused by organism, yun ang tinatawag nating infective endocarditis. Earlier, di ba, di-differentiate ko yung inflammatory. Pagka siya ay autoimmune, systemic connective tissue disease, that is inflammatory. Pero kung caused by microorganism, no, like an infected tooth, no, may bulok siyang ngipin, nagkaroon ng infection, okay? So therefore, that is infective endocarditis. So, to continue with the rheumatic carditis or endocarditis, what are the major classic symptoms? Kasi affected nga ay the connective tissue disease. So there's carditis, no? Pagka lahat ng layers, pancarditis. Connective tissue of the joint, polyarthritis. Arthritis, no, is inflammation of the joint. Pagka poly, one or more of the joints. So therefore, at ano yung palipat-lipat, no? And patient will have limited movement. There could be impaired mobility. Involvement of the nervous system. So there's chorea, Denham's chorea, or St. Vitus dance. And on the elbow, there's development of subcutaneous nodules, and on the skin, erythema marginatum. So this is a major manifestation. All right, first, carditis. No? So yung carditis, no? Initially, there is formation of ascope bodies. No? So these are lesions which are present in the heart. And because of valvular damage, there's a murmur, okay? Because of valvular damage, which can be valvular stenosis or regurgitation. You will hear the pericardial friction rub kung si patient ay may pericarditis. And all of these will lead to heart failure. Another major manifestation is polyarthritis, wherein there's swelling of several joints, no? The knees, the ankle, the hips, shoulders, no? And this is warm, red, and painful. Therefore, a patient had the chronic pain, there's impaired mobility. On and the nervous system, no? There's chorea or Sydenham's chorea or St. Vitus dance, no? Where there's involuntary grimacing, inability to use skeletal muscles in a coordinated manner because of involvement of the CNS, central nervous system. Ano pa? There is subcutaneous nodules, sometimes marble-sized nodules, no, around the joints. And then on the skin, red spotty rashes on the trunk that disappears rapidly, leaving irregular circles on the skin. Okay? So alin ang mga affected? The heart, the joints, the nervous system, the skin. Okay. What are the minor manifestations? The minor manifestations, one, is reliable history of rheumatic fever or evidence of pre-existing rheumatic disease. Pangalawa, when patient complain of joint pain, arthralgia, with in one or more joints without evidence of inflammation, tenderness, or limited movement. Third, there's fever. Yeah? So the fever could be 38.9 to 40 degrees Celsius. And blood tests reveal there's increase in ASR and ASO titer and positive C-reactive protein. Diba? ESR is erythrocyte sedimentation rate, the rate in which the RBC settles down in a test tube. Basta may inflammation, mataas yung ESR. ASO titer, anti-streptolysin O titer, indicate that the client had been exposed to GAB. C-reactive protein, diba? This is a protein which is released by the liver whenever there is inflammation. And ECG changes, there's prolonged PR interval. Okay. So, with assessment and diagnosing of a client with rheumatic fever, we use the Jones criteria. What do you mean by Jones criteria? Diagnose clinically. So the RHD is diagnosed clinically, meaning with the manifestations. Ano yung criteria? Criteria? Presence of 2 major symptoms or 1 major, 2 minor, with supporting evidence of recent streptococcal infection. Okay, so Jones criteria. At dapat ito may E'. Because this was given by Dr. Duckett Jones. Kaya pinangalan sa kanya, Jones criteria. Okay. You tell me whether major or minor. O, takpan na nga natin. Okay. Tell me whether major or minor. Fever.
Minor po.
Siyempre, no? Minor. So there is Korea. Sydenham's Korea.
Major.
Major. Arthralgia.
Minor.
Minor. Polyarthritis.
Major po.
Okay. Erythema marginatum.
Major.
Major. Subcutaneous nodule.
Major.
Major. There is elevated ESR.
20 and
Minor.
Okay, minor. Elevated C-reactive protein.
Minor.
Minor. Leukocytosis. Minor. Ayan. So, according to Jones criteria, presence of 2 major and 1 major plus 2 minor, no, with supporting evidence of recent streptococcal infection, we diagnose the patient to have rheumatic heart disease. Okay. So, management and intervention. Prevention is the best. How? By early identification and treatment of streptococcal infection. Sabi ko nga alam mo po nung nag-aaral kami noon, ako syempre, long time ago, not so long time, okay? So we were assigned na in the medical ward. Ang dami naming cases na rheumatic fever, rheumatic heart disease. Okay? Pero ngayon, less na lang ang incidence kasi alam na nga ng mga tao na pagka sila ay nag-tonsillitis, pharyngitis, pupunta na sa doktor para magamot ng tama, mabigyan ng antibiotic. Okay? So nurse must be familiar with the signs and symptoms of streptococcal pharyngitis. Okay? Na ano yon? There's fever, my chills, no, my sore throat, there's diffuse redness of the throat with exudates, no, on the oropharynx. By the way, pag halimbawa bata, hindi pa masyadong nakakareklamo na meron pala siyang tonsillitis, no, o baka delayed ang kanyang language, no, pagsasalita. Pagka yung bata ayaw dumede, ay ibig sabihin, nagugutom, bibigyan mo ng dede, kukunin, pero ibabalibag na sa iyo kasi masakit ang pagsak. At saka may drooling, no? Natululaway. Okay, there's drooling, no? So there's inflammation. There is pharyngitis, tonsillitis. Okay, so there's also enlarged and tender lymph nodes. There's cervical lymphadenopathy, common in children. Meron din silang abdominal pain, and acute sinusitis and acute otitis media. Okay, so kailangan talaga ma-examine mabuti para mabigyan siya ng gamot. So prevention is the best by prompt treatment of an upper respiratory tract infection. So the antibiotic of choice or the DOC, drug of choice is penicillin. Okay. Bakit may aspirin? Bakit may aspirin dito? It controls blood clot formation around the valves. Diba? Yung discuss ko kanina, the pathophysiology. Okay? So bibigyan siya ng aspirin because aspirin inhibit platelet aggregation. Ibig sabihin, aspirin is a blood thinner. Blood thinner, pampalabnaw ng dugo, no? Para hindi mag-blood clot. Okay. Para hindi mag-blood clot around the valves at saka doon sa may atria. Alright. Autoimmune, systemic connective tissue disease, wala tayong magagawa kung di bigyan ng steroids. Okay? Siyempre, may lagnat. E di kailangan natin ng antipyretic, paracetamol, and napapawisan. Okay, pag napapawisan, there's loss of water as well as electrolytes. So therefore, to prevent dehydration, we provide adequate hydration. Increase oral fluid intake. Kaya kung bata, no, kailangan niyang i-hospitalize, no, kasi problema natin yung hydration. Kailangan niya ng IV fluid therapy. And meron pa tayo dito antibiotic prophylaxis to prevent recurrence. Kasi ito ay paulit-ulit. So paano ito? Antibiotic prophylaxis. So the client has monthly injection of Penadur. Penadur, as you pronounce, penicillin. Okay? Monthly injection, pang matagalan. Okay. Siyempre, because of decreased cardiac output, activity intolerance, and they provide bed rest. No? Provide diversional activities that require minimal activity. Okay? Lagi sa mga bata, reading, putting puzzles together, pero avoid activities na nag-involve ng competition. Okay? Kung adult, huwag mo siyang panoorin ng basketball. Okay? So kailangan yung tahimik lang siya na walang effort na gagawain o pagka natatalo sa game board, umiinit ang ulo. Okay? And assess for progression or improvement of heart involvement. So nagpo-progress ba? Nag-heart failure na ba tayo? O nag-i-improve ba yung pasyente? Okay? So yung ating management and intervention. So when all the layers are affected, that is called pancreatitis. Next, in red, congestive heart failure and pulmonary edema. From the word heart failure, ano ang definition? Inability of the heart to pump. How many pumps? Right side and left side. The right side pump blood to the lungs for gas exchange. The left side pumps blood to aorta for systemic circulation. So, yun yung heart failure. If the left side is unable to pump blood to systemic circulation, blood is dumped back to the lungs. So there's congestion in the lungs. While if there is right side failure, there will be congestion in systemic circulation. Kaya with heart failure, it follows congestive heart failure. Okay? Kaya ang types, left-sided, right-sided failure. I have here some of the causes, like damage to the muscular wall, when there's myocardial infarction, when there's cardiomyopathy, kanina, when there's hypertension, because of increase in afterload, coronary artery diseases, ayun, valvular defects, no? And when there's infection, yung ating mga infectious disorders, no? Na meron tayong pericarditis, myocarditis, endocarditis. Okay. Pero do not limit yourself to these causes. Hindi lang yan. Marami pa sila. So, these are the causes according to altered physiology. 1. When the preload is greatly reduced. Kailan yun? When the preload is greatly reduced. When there is hypovolemia. At maraming ang causes of hypovolemia nga, di ba? Pero the very common sa inyo ay yung postpartum na nagkaroon ng postpartum bleeding. Sino pa ang nagkakaroon ng hypovolemia? Yung pasyente na nagkaroon ng massive GI bleeding. Bilhin mo, there's massive hematemesis. Tapos may bleeding din siya sa baba, melena, and hematochezia. This can also cause hypovolemia. Or the client has diabetes insipidus. Diabetes insipidus is a disorder wherein there's deficiency of anti-diuretic hormone. Second, the antidiuretic hormone is produced by the hypothalamus and stored by the posterior pituitary gland. Pero pagka nagkaroon ng head trauma, affected yung production and release of antidiuretic hormone. And that is called diabetes insipidus. Do you know? The patient can have a urine output of 5 liters, 10 liters, 15 liters a day. So it leads to severe dehydration. Ayun. Preload is greatly reduced. Ibig sabihin, less ang blood na pumapasok sa puso to meet the demands of the body. Magko-compensate siya. Paano siya magko-compensate? No? So by dilation, by hypertrophy, and by tachycardia. Pero mapapagod din siya. Parang ganito. Kung ikaw ay papasok ng Monday to Saturday, isa lang uniforme mo. Isa lang uniforme. Para makapasok ka sa school ng malinis, ang iyong uniforme, maglalaba ka araw-araw. Diba? Maglalaba ka araw-araw, magpa-plancha. Okay? At nakakapagod yung maglaba araw-araw. Okay? Eh kung isang piraso lang, alam mo, i-washing machine mo pa, na isang piraso lang. Okay? Another, if the client has severe anemia, there'll be decreased oxygen carrying capacity of the blood. Ano yung tinatawag natin severe anemia? Na yung kanyang hemoglobin ay 7, 6 grams. So there'll be decreased oxygen carrying capacity of the blood, kaya magpo-compensate ang puso. Okay? So una makaka-compensate yan, but later on, mapapagod din siya. Ayun. Preload, greatly reduce. Pangalawa, preload, greatly increase. Kailan naman yon? When there is hypervolemia. Diba? There's fluid overload. Like si patient na may renal failure. Yun ang kinakatakot natin sa kanya. Pagka siya may renal failure, wala nang urine output, expect there's fluid retention. The patient has weight gain. The patient has edema. Okay? And worse, has generalized edema. Edi greatly increase ang preload. Ay nakakapagod talaga yon sa puso. Kaya si patient na may renal failure, bantayan mo yan na may heart failure. Mag-pulmonary congestion, pulmonary. Okay? So there's fluid overload. Another. Patient has polycythemia. Polycythemia. Ito ay opposite anemia. Kung si anemia is decrease in blood cells, si polycythemia naman has increased blood cells. RBC niya, mga 18, 20 grams ang kanyang RBC. Pero hindi lang RBC pati WBC, pati platelets. And that is cancer of the blood. There's abnormal proliferation of blood cells in the bone marrow. Kaya malapot talaga ang dugo. There's increase in blood viscosity. Increase in blood viscosity and increase in blood pressure. So that is increase in preload. Okay? Third, afterload is obstructed or difficult. Okay lang nga yun? The resistance that the heart has to overcome is increased, obstructed, or difficult. Like when there is valvular stenosis and valvular regurgitation. Aortic stenosis, pulmonic stenosis, mitral stenosis. Okay? So it's obstructed or difficult. Or dili kaya, mataas masyado yung blood pressure. Hypertension. Okay. Natanong ko nga kayo, ano yung pinakamataas na blood pressure na nakuha nyo? Probably 180, 200, no? Would you imagine? Yung pasyente, 300. Grabe yun kakayanin ba ng puso yun? Sobrang taas ang afterload. Ayun, si patient. BP of 300, no? Over 150. So the patient died of heart failure. Okay? Damage to the heart muscle. Example nga nito, myocardial infarction. cardiomyopathy. Okay. Increased metabolic state, meaning there's hypermetabolism. Kailan yon? Hypermetabolism, a thyroid gland disorder. Hyperfunction of the thyroid gland. Yung mga Graves' disease, which is also an autoimmune. Na-increase ang T3, T4. Increase T3, no? So, triiodothyronine and thyroxine. They have fever. There's hypercatabolic state. There's tachycardia. There's hypertension. Okay, there's CNS irritability. No? Increased metabolic state. Another. Pheochromocytoma. Pheochromocytoma is a tumor of adrenal medulla. Diba? We have adrenal gland, we have the adrenal cortex, adrenal medulla. If you recall your anatomy, ano nga ba yung hormone secreted by adrenal medulla? Sige nga. I hope na-recall nyo. Hormone secreted by adrenal medulla. Oh, napaka-importante anatomy. Hormone secreted by adrenal medulla are the catecholamines. These are the epinephrine and norepinephrine. So anong effect nun? So the patient has tachycardia, the patient has hypertension. So therefore, nakakapagod yun para sa puso. Okay? So these are among the causes of CHF according to altered physiology. Pero, magko-compensate si puso. What are the compensatory mechanisms of the heart? Isa nga, ventricular dilatation. This is stretching of the heart muscles. Kasi pag nag-stretch siya, diba, during diastole, diba, there's stretching of the heart muscle. During diastole, there'll be more ventricular filling. And therefore, it will be able to create a greater contraction. But that stretching is effective only up to certain level. Okay, the more stressed the heart muscles are, more ventricular filling, greater contraction. That is Frank Starling law. But that is effective only up to certain level. Beyond physiologic level, kung hanggang saan lang ang nakayanan ng puso, beyond that, there will already be decompensation. Pangalawa, ventricular hypertrophy. So ito nga yung tinatawag natin na increase in size and diameter of the heart muscle. Lalaki ang puso. Okay. And another mechanism is CNS stimulation by tachycardia. Bibilisan ko pa ang pag-pump. Okay. Tingnan mo. Nung siya ay nag-stretch, more ventricular filling, nung siya ay lumaki, hypertrophy, anong effect on the demand for oxygen? Anong demand sa pangangailangan niya mismo para magawa natin ito? Anong demand for oxygen? High or low? Anong demand for oxygen? High or low? Please answer. Anong demand for oxygen? Increased demand for oxygen. So therefore, habang nagko-compensate si puso, siya rin ang parang ginigisa sa sarili niyang mantika. Habang siya ay nagko-compensate, mas dumadami ang pangangailangan niya na siya pa rin ang magtatrabaho. Okay? So, ventricular hypertrophy, increase in size and diameter of the myocardial cells. Para bang kumuha tayo dito ng dalawang lalaki, magkakaklase. Yung isa payat, yung isa medyo matipunong katawan, malalaki ang kanyang mga muscle. Bunong braso tayo, bunong braso. Siyempre, sino ang mas malakas? yung mga laki ang katawan. So parang ganito rin, si puso malaki. So therefore, it will be able to create a greater contraction. So these are effective up to certain level. So again, how does it work? Halimbawa, meron tayo dito aortic stenosis. There's inadequate opening of the valve, aortic valve. So increase after load. Diba? Who is the first to be affected? The first to be affected, si left ventricle. Si left ventricle, di ba? Anong gagawin niya? Para makalusot ako dito. Okay, para makalusot ako dito sa makipot na daan na yan. Okay, so anong gagawin niya? Mag-stretch siya. lalaki pa siya. Magtatakikardia pa ako. Okay? Para malakas ang aking cardiac contraction. So that I can push blood dito sa high resistance na to, na aortic valve, para makapampa ko ng good cardiac output. Kaya there's complete emptying of the ventricle. Ayan, okay ang compensatory ko. Pero sooner or later, pagod na ako, suko na ako, ayoko na. Okay, so ano mangyayari? Suko na ako. Okay, there is now incomplete emptying of the ventricle. Okay, there's now incomplete emptying of the left ventricle. Ibig sabihin, there's retention of blood in the left ventricle. Dapat yung dugo dito papasok na dyan dahil may traffic dito, there's incomplete emptying of the left ventricle, unable to accommodate blood coming from the left atrium. And therefore, blood will be dumped back to pulmonary vein to the lungs. Okay? So, pagka may left side failure, congestion is in the lungs. Para hindi makalimutan, left side failure, lungs. Ano bang process ang nangyayari in the lungs? Diba, we have gas exchange. Kaya magkakaroon ng impaired gas exchange. So pag may left side failure, ano nga ang cardiac output niya? Low. So there's decreased cardiac output. Yun ang forward effect. Yun ang forward effect ni left side failure. Low cardiac output. And bakit sinabing backward effect? Backward effect. Kasi nga, there's a tension of blood in the left ventricle, left atrium, and to the lungs. Kaya there is pulmonary congestion, nursing diagnosis, impaired gas exchange. Okay. And worst scenario, may pulmonary edema. Pulmonary edema is when the fluids are actually in the alveoli. So what are the signs and symptoms? Ito na, inuubo na yung pasyente, okay, with a pink frothy sputum. Ang sputum niya ay mabula, may air. Ano pa? Ito yung may orthopnea, may PSP, nocturnal dyspnea. Okay. Ayun, no? Referable to the lungs. Ayan. Okay? So there's impaired gas exchange, and there could be cyanosis and signs of hypoxia. Ano ang ating PCWP? The PCWP, pulmonary artery capillary wedge pressure, is high. Or pulmonary capillary wedge pressure, or PAWP, high. And ang normal nga natin, 40-12 mm mercury. Ito, mga 20, 25. Pagka 25, there's already an indication of impending pulmonary edema. Okay. Balikan natin to. Decreased cardiac output. Forward effect. That is forward effect. Decreased tissue perfusion to the brain. Altered level of consciousness. Disorientation, confusion. Altered renal perfusion. Oliguria. Then, tataas ang BUN creatinine levels. Patient will have electrolyte imbalance, particularly potassium imbalance. Ayun. Tapos, because of altered tissue perfusion to all the body cells, pagod na pagod siya. Fatigue, activity intolerance. Ayan, no? Activity intolerance and signs of decreased tissue perfusion. Okay? Naintindihan po yung left side? So there are two effects. One is the backward effect kasi the fluid are dumped back in the lungs, and forward effect because of decreased cardiac output. There'll be altered tissue perfusion, activity intolerance. Now, pagka may congestion in the lungs, mahirapan na mag-pump si right side. Di ba si right side niya ang nagpa-pump ng dugo via the pulmonic valve to the lungs. Pero may resistance nga dito eh. Mataas ang resistance, ang hirap ng mag-ano dito kasi may congestion na tayo sa lungs. Kaya pag may left side failure, sooner or later, there will be right side failure. Hindi natin alam kung hanggang saan ang kaya ng puso. Kaya sooner or later. Surely, 100%, pag may left side failure, susunod si right side. Pero pwede ba na mag-right side failure na wala naman siyang left failure? Pwede ba? Yes. So, pwede. How? Halimbawa, ito man ang narrowed. Pulmonic stenosis. O kaya may COPD. Okay? Pulmonic stenosis o kaya may chronic obstructive lung disease. Kaya mahihirapan si right ventricle to pump blood, no, to pulmonary artery to the lungs for gas exchange. So yun ang effect niya. While if the right ventricle is unable to eject blood, adequate blood to pulmonary artery, then blood will be dumped back to the right ventricle. Okay? So blood will be dumped back to the right ventricle because of retention of blood, unable to accommodate blood coming from the right atrium. So blood will be dumped back to the superior inferior vena cava. Kaya, anong makikita mo dito sa taas? There'll be distended neck veins. Tataas ang central venous pressure. Okay. O dito naman, blood will be dumped back sa GIT. Kaya there'll be organomegaly. Sino ang lalaki? Anong organ? The spleen, splenomegaly, the liver, hepatomegaly. At masisira din ang liver. So it can cause liver cirrhosis because of heart failure. Yun ang tinatawag nating cardiac cirrhosis, cardiac liver cirrhosis. Okay? Tapos mayroon din siyang leg edema, mayroon siyang ascites, no? Accumulation of fluid in the abdomen. All of these can lead to abdominal discomfort. Kaya wala siyang ganang kumain. Okay? So, again, using this diagram, pag may right side failure, there will be congestion in the peripheral tissue. Kaya magkaroon nga siya ng leg edema. Ayun, no? Dependent edema and ascites. Ascites, accumulation of fluids in the abdomen. There is liver congestion. No, ayun nga. There is hepatomegaly. And signs of impaired liver function. Ang ebidensya. Tataas yung SGPT, SGOT. Serum glutamic pyruvic transaminase and serum glutamic oxaloacetic transaminase. Ayun. GI congestion. So there will be anorexia, GI distress. Pagka may GI distress, wala na siyang ganang kumain. And because of decreased intake of nutrients, so there will be some degree of weight loss. Kaya lang, because of edema, mas malalaig yung weight gain because of edema. Pagka nauna si left side, sooner or later, magkakaroon ng right side failure. Pero pwede ka rin mag-right side failure na wala kang left side failure. Not necessarily susunod si left side. Okay, questions so far? Okay, so in here, no, so marami tayong cause na sinabi. Pero in here, in this slide, one of the cause is there's damage, no? There's damage, no, into the heart muscle. So there is a myocardial infarction, and the damaged cells will not be able to perform a good pump. Kaya there's congestion in the lungs where gas exchange happen. Kaya pakiramdam ng pasyente feel like they are drowning. Okay, humihingi ng tulong, no, kasi para silang nalulunod. Okay, and when we assess, no, so we assess for just remember there's simple examples, no. Na, because fluids back up into the lungs, okay? So therefore, ang heart sounds daw na maririnig mo resembles that of a galloping horse. Or dili kaya yung lung sounds that you would hear ay parang when you blow back, no, through a straw in a can of soda. Subukan mo na You have the can of soda, can of Coke, no? So you use the straw, you blow, and the sounds that you will hear ay ito yung ating mga crackles or rals na maririnig mo pagka siya ay may heart failure, there's congestion in the lungs. Okay. So diagnostic findings, no? So chest x-ray, ano makikita? Okay, oh, chest x-ray, myocardio-megaly. All right. And my pleural effusion. There's also abnormal volume of fluid in the pleural cavity. That's called pleural effusion. ECG reveals no, abnormal findings because of ventricular hypertrophy as well as dysrhythmias. To the echocardiogram reveals cardiac valvular changes. Makikita na may valvular stenosis, valvular regurgitation, as well as pericardial effusion. No? So there's chamber enlargement, no? Meaning there's dilation and ventricular hypertrophy. Yan ang makikita mo sa pasyente na may heart failure. So therefore, ano ang diet natin? The diet order. No? Kasi mayroon na silang congestion, may edema, may weight gain, place on low sodium diet, and fluid restriction. May IV fluid? Yes. Pero regulated KVO just to keep the vein open. E para saan yung IV line natin? For medication. Kasi magbibigay tayo ng IV medication. Okay. Ano mang gamot? 1. Inotropic agents. Ano nga yung inotropics? Example is the digoxin or lanoxin. It increases the force of cardiac contraction. Iba yung ating digitalis. It increases the force of cardiac contraction. Kung si patient na nagtatakicardia kanina, nagtatakicardia, ito ngayon, it increases the force of cardiac contraction. And therefore, it increases stroke volume. Okay. And it slows down heart rate. It slows down heart rate. It slows down conduction. Applying now pharmacology. It increases the force of cardiac contraction. Positive inotropic effect. Positive. Kasi it strengthens. Decrease heart rate. E diba? Negative. Negative chronotropic effect. It decreases heart rate. It decreases conduction. Negative dromotropic effect. It decreases conduction going to the AV node. Okay? It increases the force of cardiac contraction. Positive inotropic effect. Decreases heart rate. Negative chronotropic effect. It decreases conduction. That is negative dromotropic effect. It decreases sympathetic activity. And it stimulates parasympathetic activity. So when you administer digitalis, the earliest sign of digitalis toxicity is bradycardia. Kaya SOP, wherever you are, whether in the Philippines, Singapore, or abroad, okay? So you have to check heart rate. Below 60, do not administer. So apply natin. Heart rate is 100. Would you give the digitalis? Yes or no? Heart rate. Okay. Yes po. Okay, thank you, Miss Alibudbud. Bibigay natin yung digitalis. Heart rate 50. Would you give digitalis? No po. Correct. Thank you. No way. And Miss Alibudbud. Okay. Heart rate 59. Heart rate 59. Would you give? No. Tama. Hindi natin bibigay. Heart rate 60. Heart rate 60. Would you give? Yes po. Tama. At makikita nyo yan. Actually, in-specify talaga ng doktor. Below 60, do not administer. Kasi, ano yung normal heart rate? 60 to 100. Parang ano yan, no? The first time that this was asked in the local board exam natin, punta mga estudyante, back to school. Okay, ma'am, yung pong 60 heart rate, normal, bradycardia, tachycardia. Siyempre, hindi tachycardia yun, di ba? 60. Ano, normal or brady? Normal or brady? 60. Okay, tama. Okay, from section 12, no? So, normal. Pero kasi nag-iisip ka pa, ano nga ba? Eh, kasi that is the lowest boundary, di ba? 60 to 100. Okay, talaga, that is universally accepted yun, na talagang heart rate is between 60 to 100. Below 60, do not administer. At kung below 60, nurse, examine your patient for signs of digitalis toxicity. Watch out. Watch out for digital toxicity like loss of appetite, nausea and vomiting, rapid slow irregular heart rate. There could be disturbance in color vision, and anticipate an order for digoxin level. And the normal digoxin level, the therapeutic level of digoxin is 0.5 to 2 nanogram per ml. Anticipate, si doctor will request for serum electrolytes, particularly potassium. Eh bakit mag-request pa ng serum electrolyte? Kasi, di ba, heart failure tayo. Ang isang gamot na bibigay dyan ay furosemide. Furosemide, no? IV, injection. Eh ano nga ba ang effect ni furosemide? Diba, furosemide will inhibit the absorption of sodium and water, and there is loss of potassium. Kaya pagka naka-furosemide siya, mag-hypokalemia. And under hypokalemic state, the client is at risk to develop digitalis toxicity. Kaya, i-evaluate ang serum potassium level. Pag siya ay mababa, ang normal is 3.5 to 5. Pagka mababa ang serum potassium, expect bibigyan natin ng potassium supplement. Okay? Kasi potassium as well has direct effect on the heart. It has direct effect on cardiac contraction. Okay? So, another diuretic which will be given is chlorothiazide or diureal. Okay, sample computation lang tayo. The order is 160 milligrams of furosemide now through IVT. Okay, ano ang doctor's order? Furosemide, 160 milligrams. The SAC, 20 milligrams per 2 ml per ampule. How many ml would you administer? Okay? Compute. Maghintay ako dito. What's your answer? Simple math. Pagaling sa math. Furosemide, 160 milligrams. Ang stock, 20 milligram per 2 ml per ampule. How many ml would you give? Nurse, heart failure ha. Pulmonary congestion na tayo ha. Malapit lang mag-pulmonary edema. Okay? Ready ka na. Furosemide. Okay, compute. Okay, uy, wala pang answer sa chat. Wait lang tayo. Hanggang kailan tayo maghihintay? Hanggang bukas. Okay, tingnan natin ang unang sumagot din eh. 2 ml, sabi ni Sheila Marie. Please recompute. Kasi di ba ang order 160 milligrams. Sabi ni Eunice Alibudbud, 16 ml. Correct ka dyan. Anong computation? 160 milligrams over 20 milligrams times 2 ml. And then 160 divided by 2 is 8. No? 20 milligrams eh. 160 divided by 20 is 8 times 2 ml. That is 16 ml. Correct. Nurse, sige, pakibili mo to sa pharmacy. How many ampules would you buy? How many ampules would you buy? Okay, compute. How many ampules would you buy to the pharmacy? Compute. Dapat magaling ang nurse sa math. Nahirapan ang huminga si patient. You have to position the client sitting really upright. Eye fowlers. Okay. Mabilis tayo. Ilan ang bibilhin? Paano? Di ba? 160 milligram. Anong stock? 20 milligrams per ampule. Per ampule. So how many ampules would you buy? Compute. 8. Thank you. Sabi ni Dayan. Okay, so dagdagan na. 8 ampules. Sabi ni Leah Kyla, 8. Christine, 8. You are both correct. Sabi ng student, ma'am, ganito po kadami? Yes. Okay. So 8 ampules to be given direct IV push. Direct IV push. Okay. Nurse, when do you begin to see the effect of furosemide IV? When do you begin to see the effect of furosemide IV? One day ba yan? Isang oras? When do you begin to see the effect of furosemide IV? Mabilis lang. Within 5 minutes. Thank you, Christina Marquez. Now, within 5 minutes. How would you know that furosemide is obtaining its therapeutic effect? Siyempre, there's increased urine output. Okay? So, nag-diurese si patient. Kaya naginhawahan ang puso. Gaganda na yung ating gas exchange. So the patient will have the initial dose at hindi lang ito, no? Patient will have another dose na yan ng 20 milligrams every 4 hours or every 6 hours. Other than may maintenance pa yan. May maintenance pa yan ng tablet, no? So 40 milligram per tablet na furosemide. By the way, mayroon ding questions, no? Ito ay stat now, so can be given now na anytime. Pero kung siya ay may maintenance na furosemide tablet, it is best given in the morning. Huwag mo ibibigay sa gabi na kasi nakalimutan ko na ibigay sa umaga kaya binigay sa gabi. Tapos si patient nag-complain sa doktor kinabukasan. Atok, hindi po ako nakakatulog. Bakit naman? Ihi po ako ng ihi eh. Kasi nabigyan pala siya ng furosemide sa gabi. Okay? So it is best given in the morning. All right. So another drug which will be given is dopamine or intropine o kaya yung ating dobutamine. Okay. So, you know, dopamine, this is also, this will improve tissue perfusion. It will also improve renal perfusion in low dose. Okay? Kaya 'di ba hindi naman problema yung yung blood pressure kasi mataas nga yung blood pressure eh. Pero bibigyan natin ng dopamine. Because dopamine, intropine is a vasopressor. But at the same time, it also improves tissue perfusion and therefore will prevent kidney complication. Okay? It will prevent renal failure kasi gaganda yung renal perfusion. Okay? So, low sodium diet, inotropics, and then dopamine falls under inotropic because it increases the force of cardiac contraction. Balikan ko lang yung digitalis. Ano nga effect ng digitalis? It increases the force of cardiac contraction and therefore it increases stroke volume, it increases cardiac output, it increases renal perfusion, maganda yung urine output. Question, does digitalis has diuretic effect? Yes or no? Si digitalis ba has diuretic effect? Yes or no? Tama yung effect ng gamot. It increases the force of cardiac contraction and therefore it increases stroke volume and cardiac output. Pag nag-increase ang cardiac output, gaganda ang renal perfusion, gaganda ang urine output. May diuretic effect? Yes or no? Okay. So may diuretic effect ba? Yes. Thank you, Christine. Ayan, no? Thank you, Christine. May salibudbud. No? It has diuretic effect. So nakakapagpaihi sa kanya yung ating digitalis plus yung furosemide. Alright. So, pagka naka-furosemide, tapos nag-hypokalemia, watch out for signs of muscle weakness, okay? Cardiac arrhythmias, at kung kinakailangan, bibigyan niya siya ng potassium supplement. O kaya diet, which are good sources of potassium. Dahil binigyan natin ng furosemide, nag-hypokalemia. Kaya, bigyan natin ng diet high in potassium. Example, diet. So, diet high in potassium. Diet high in potassium. Okay. So, diet high in potassium. Correct. Banana, avocado. Panahon ngayon ng mga pakwan, melon. They are good sources of potassium. Can we give this to our patient? Yes or no? Ang sarap pa naman ng pakwan, di ba? Ang pakwan, hiwain mo, ilagay mo sa refrigerator, malamig, ang sarap kainin. Okay? So, pwede ba sa kanya? Yes or no? Yes or no? Pwede? Answer, yes or no? Yes po. In the contrary, although it is rich in potassium, masarap, pero hindi natin pwedeng ibigay. Bakit? Di ba matubig yun? Matubig yung pakwan. Matubig yung melon. Kaya hindi natin pwedeng ibigay. So gamitin natin yung mga dry, no? Like banana, avocado, but not the melon and watermelons. Kung wala siyang heart problem, at gusto mo lang ay good source of potassium, pwede yung mga watermelon and melon, but not for patient with heart failure. Okay? So, patient is also given vasodilators like nitroglycerin. So, nitroglycerin, yung pwede rin place in the chest wall because this would cause a vasodilation of the coronary artery and therefore improve blood supply to the heart. ACE inhibitor din. Di ba, they have hypertension. Kaya ang gamot mismo na kailangan nila ay ACE inhibitor other than other antihypertensive medication. Bakit kaya? Di ba? Trace natin yung patophy. Nung may decreased cardiac output, there's altered renal perfusion, meaning decreased blood flow to the kidney. So the kidney will produce or release renin. Renin plus one substance will form angiotensin 1, plus another substance will form angiotensin 2. And angiotensin 2 is a potent vasoconstrictor, and there will be increase in blood pressure. And it will also promote the release of aldosterone by the adrenal cortex. And aldosterone promotes sodium and water retention. Di lalong mag-iidim ang pasyente. Kaya ang kailangang bigyan natin, ACE inhibitor. It will block conversion of angiotensin 1 to angiotensin 2. Kaya sinabi, ACE, okay? ACE inhibitor, angiotensin converting enzyme inhibitor. Na ang tunog, pril. Ano yung mga pril na yun? Ramipril, enalapril, kinapril, ayan, captopril. Lahat ng pril except si April. Ayan, si April po ay hindi ACE inhibitor. Ayun. Okay, so thank you. Elaine Serafica, no? Captopril is an example of ACE inhibitor. Okay? So, yan ang ating management of heart failure. Okay. So, as nurses, nursing management, sorry. Most clients manage chronic heart failure at home. Oo nga. Kung hindi lang sila nahihirapang huminga, ay nasa bahay lang sila. Tutuloy lang nila yung gamot. By the way, board question, mainstay treatment, mainstay is digitalis. Kaya they must be taught how to take their own heart rate. So sila ay nasa bahay lang. Kailan niya pupunta sa ospital? Kung sakali, no, na nagpupulmonary congestion, talagang nahirapang huminga. Ganun pa man, may nakahanda na rin sa bahay na oxygen tank. At saka, nabili na rin sila ng pulse ox, no? Pulse oximeter para alam nila kung kailan sila pupunta sa ospital. Gawang ano, di ba, mga takot pa rin tayo na pumunta sa ospital, baka mga COVID patients pa rin doon. Okay? Kaya usually they're managed at home. But marami silang medications na iinumin, no? They need to change lifestyle, diet restrictions, in order to control heart failure. And they have to administer prescribed medication and monitor for therapeutic effect and adverse effect. Kaya they must be taught how to count the heart rate. Kasi below 60, hindi bibigay yung digitalis. Promote heart's ability to eject as much blood as possible, no? By giving the cardiotonic drugs. Monitor for signs of excess fluid volume, no? Yung mga edema, weight gain, okay, and electrolyte imbalances, particularly potassium imbalance. Promote oxygenation, balance activity according to client's tolerance. Okay? So, as much as possible, the patient is placed on complete bed rest. Pero kung simply maglalaba lang siya, napapagod, so ibig sabihin, hindi pa niya kayang maglaba. Okay? And we have to support family members. Kasi kailangan ng support na din talaga ng family members. No? Hindi pwedeng mag-isa lang ang pasyente na dealing with his own care. Okay. So, in summary, ano nga bang effect ng digitalis? Mechanism of action? Positive inotropic effect. It increases the force of cardiac contraction. Slows down heart rate? Negative chronotropic effect. Slows conduction? Negative dromotropic effect. The therapeutic level? 0.5 to 2 nanogram per ml. Ang NCLEX question dyan. NCLEX question is alin dyan ang digitalis toxicity. Okay? Ganito ang tip. Halimbawa, hindi mo alam ang normal digoxin level. Tapos meron ka dyang 0.5 choice, 0.5, 1, 2, meron kang 3. How would you answer? Siyempre, yung pinakamataas na numero. Okay, which is 3. Tama ka dun, nakahula ka dun. Okay, so there is digitalis toxicity and be ready to administer the antidote. And the antidote is Digibind. Ang dali din memorize. Diba? Digibind. It will bind with digitalis receptor sites and therefore reverse the effect on the heart. Okay? So kapwa, meron tayong protamine sulfate, no? Meron tayong vitamin K ngayon, Digibind. So check potassium level because under hypokalemic state, the client's at risk to develop digitalis toxicity. Okay. Identify. Left or right? Left-sided or right-sided failure? Ruckles. Answer. Please open your microphone. Okay.
Left side po.
Okay. Diba? Sabi natin para madaling maalala, no? Pagka lung manifestation, left side. So, tama. Left side. Distended neck veins.
Right side po.
Okay. So, distended neck vein is correct. Right side. Okay. Orthopnea. Orthopnea. Nalulunod siya pag nakaupo. No? Ano yon?
Left side po.
Left side, tama. No? Tama, Janice. Okay. Hepatomegaly.
Right
Right
side.
side.
Right.
Correct. Fatigue.
Right.
Fatigue.
Ay. Left po
Isip-isip.
ata.
Fatigue. Madaling mapagod because of there's activity intolerance because of decreased cardiac output. So therefore, left side. Diba? Di ba ang left side has two effect. One is backward effect na napunta sa lungs. Ang forward effect is because of decreased cardiac output, altered tissue perfusion, activity intolerance. So fatigue is left side. Okay. Next, leg edema. Leg edema.
Right side.
Right side po.
Correct. Oliguria.
Left side.
Left side.
Left side. Correct. Ascites.
Right side.
Right side po.
Right side. Correct. Disorientation.
Left
side.
side.
Left side. Okay. Abdominal discomfort.
Right side.
Right side.
Correct. Yan ang simple. Kasi kung gusto nyo, gawin natin complicated. Left side forward effect. Left side backward effect. Ayan. Pero okay na to. Kasi nice na lang yon. Nice to know. Ito, you should know whether left or right side. Okay? So thank you for your participation. Next. Pulmonary edema. Pag sinabi natin pulmonary edema, there's fluid accumulation in the lungs. Fluid in the lungs. Usually a complication of left side failure. Diba? Worst complication of left side failure is pulmonary edema. Cardiogenic cause. Pero marami din palang non-cardiogenic. Non-cardiogenic cause is when there's pulmonary embolism. So ito nga yung may nagbara sa pulmonary artery branch. So therefore, there's decreased oxygen. There's decreased blood flow to the lungs. Kaya mamamaga ang lungs. Magkakaroon ng pulmonary edema. Infection, like severe pneumonia. Okay? Alteration of pulmonary capillary membrane, most especially pagka may burn injury, inhalation injury. Yung pasyente, a victim of burn, tapos nalanghap niya yung superheated smoke. O yung init nun, di ba? Superheated smoke. Nasubukan niyo ba yung, ako baka hindi kayo gumagamit ng takore kasi may heater kayo. No? So, o dili kaya yung kanin, kaldero, mainit, buksan mo. Di ba ang init ng singaw? Eh ito, nalanghap mo, superheated smoke, nalanghap mo. Okay, so therefore, namaga ang lungs. Pulmonary edema. Okay? Pero most common cause, cardiogenic. Left side, failure. Katatapos lang natin yun, ha? So, there are fluids in the alveoli. What process occurs in the alveoli? Di ba gas exchange? Gas exchange occurs in the alveoli. Gas exchange occurs between alveoli and pulmonary. And ayan yung mga pulmonary capillaries, no? Yung mga pulmonary capillaries. So therefore, there'll be impaired gas exchange. Pag sinabi natin pulmonary congestion, pag sinabi natin pulmonary congestion, yung fluid nandito lang in between alveoli. In between alveolar spaces. Pero kung nandito mismo, inside, ayun, no? Fluid in the air sacs or alveoli in the lungs, yan yung pulmonary edema. So therefore, which is more serious, congestion or pulmonary edema? So yun ang mas serious. Siyempre, pulmonary edema. Okay. So ang main problem natin dito, mahirapan siyang huminga. Okay? And what are the assessment findings? No? So assessment findings natin, there's dyspnea, there's wheezing, orthopnea, restlessness. No? Naku, pupunta na kayo sa bedside. Basta ang pasyente nyo ay restless, hindi mapalagay, disorientation. No? Hindi nyo kinakausap pa yung pasyente, kaya hindi nyo alam kung disoriented siya. Pero siya hindi mapakali, hindi siya mailagay sa isang lugar. restless, decreased cerebral perfusion. Kasi di ba sabi natin, there's impaired gas exchange. And of course, there'll be productive cough, there's pink, frothy, sputum. And the result of our ABG natin is there is severe hypoxemia. Kaya ang PaO2 is below 50. Tapos, there's retention of carbon dioxide. So, the carbon dioxide is more than 50. Okay? So, there's also tachycardia, apprehension, and metabolic acidosis. So, ABG reveals respiratory, metabolic acidosis. PaO2, less than 50 mm mercury. PaCO2, more than 50. Kaya sabi ng matatanda, 50-50 po siya. Ibig sabihin, 50% chance na mabubuhay, 50% chance that the client is going to die. Okay? Tama naman sa ABG, arterial blood gas, severe hypoxemia. And there is respiratory acidosis because of poor gas exchange between alveoli and pulmonary capillary bed. There's syempre altered tissue perfusion, oxygen will not be delivered to all the cells. And there's retention of carbon dioxide in the cell. There's metabolic acidosis, metabolic and respiratory acidosis. pH, high or low? Anong blood pH? High or low? Ano nga yung normal blood pH? 7.35 to 7.45. Ano ang pH? High or low? Sagot. Ano ang blood pH? Okay, so tingnan natin dito. Sabi ni Janice, Kate, high. Thank you. Hindi. Okay, sorry. Ano ang pH? Ang pH?
Low po.
Low. Ayun. Alright. So, the pH is low. Ayun. So, the pH will determine the acidity or alkalinity of blood. pH is low, there is acidosis. Metabolic and respiratory acidosis incompatible with life. Okay, so this is the most severe complication of left-sided failure. So therefore, the medical management effort is made to relieve lung congestion. Just like kanina natin, no? Anong mga drugs nga natin? Inotropic drugs, like digitalis. Nasa samambati natin ng dopamine, intropine, or Wtrex. Okay. Diuretics, no? Like furosemide. Vasodilators, no? Like nitrates and ACE inhibitor. Lagyan pa natin ng calcium channel blockers. Morphine. Ito yung naiba dito. Kasi di ba, the patient is very apprehensive, very anxious, na sobrang hirap na nararamdaman niya. Parang may feeling na the patient is going to die. There's severe anxiety. May bibigyan natin ng morphine. Anong effect ng morphine? Morphine causes muscle relaxation and reduces work of breathing. Kaya, mas maganda ang kanyang paghinga. Maganda yung pasok ng hangin. After all, binibigyan na natin siya ng mga gamot. Okay? It will also lessen anxiety. Okay? Kaya may morphine. And, of course, we have to give supplemental oxygen. Now, if drug therapy and oxygen is inadequate, then invasive procedures, the patient will be inserted with artificial airway, endotracheal tube, and kailangan niya ng ventilator or respirator. Basta severe hypoxemia, cyanotic na yung pasyente, 50-50, magtutubo na tayo. ET, endotracheal tube insertion, connect to the respirator. Our ET, endotracheal tube, our respirator, useless if the airway is obstructed. What is the most common cause of airway obstruction? Accumulation of secretion. Therefore, nurse, the most important nursing responsibility natin is to do suctioning. Suction the nose, suction the mouth, suction the endotracheal tube. Ilang suction catheters gamit mo? 3. Okay. So, huwag yung ginamit mo sa ilong, sa bibig, gagamitin mo doon sa endotracheal tube. So, kailangan mo ng 3 suction catheters. And the longest period of time to do suction is, ano yung longest period of time to do suctioning? 10 to 15 seconds. Because with suctioning, you remove not only secretion, but even oxygen. So we have to do suctioning aseptically. Okay? Kung sakali na ang pasyente ay nakasurvive pa within 1 week at kailangan pa niya ng artificial airway, then the doctor will create a more permanent artificial airway, which is that of tracheostomy tube. Okay? Pati yung mga respirator, kay bata at isip bata, nagagalawin nyo ang mga knob settings. Ito ay sinet up ng doktor based on the result of the ABG. Okay, but can we turn patient to the sides? Definitely, yes. We can turn patient to sides, no? Pero you have to adjust the tubing, you have to adjust the corrugated tube. Kasi baka pag tagilid, no, nahatak yung corrugated tube, na-disconnect yung respirator doon sa ET, endotracheal tube. Can you feed patient? Okay. If the patient is severely dyspneic, probably will be placed on NPO. Okay? Pero if allowed, no, pwede rin pakainin, but through NGT. Okay. Can we, of course, all the comfort measures can be done for the patient. No? So dyan tayo, maraming magagawa sa pasyente. So do or provide holistic care. Okay, so you provide comfort measures, no? You prevent bed sore, particularly by turning to sides every 2 hours. Okay, change position frequently. Range of motion exercises, no, can be passive kung ang pasyente has altered level of consciousness, or active kung gising ang pasyente. Okay, so I guess this is the end of our slide, our discussion for today. Any question po? Clarification? Next tayo. Week 2. If you check your canvas, week 2 is coronary artery diseases. So ito yung angina pectoris, myocardial infarction. Next meeting. Okay, pakisundan lang po ang ating canvas. Okay, questions, clarifications? Kung wala pong questions, clarifications, then we'll have the quiz. The quiz is set at 2:20. Ang oras na ba? Okay. Dalawang quizzes natin. It is set at 2:20 to 2:40. And another quiz 2 is 2:45 hanggang 3:05. Okay? Questions? Okay po ba? Naintindihan ba? Can you follow? Yes? Oh, this is section 10, 11, 12. Na? Okay. Kung wala pong questions, so thank you very much. Bye.
Thank you po, ma'am.
Thank you